Lau. I'm from the Division of Neurology, and today I'm going to cover two lectures. The first one is on multiple sclerosis and neuro, or actually MS and related diseases, and the second one will be on neuromuscular diseases. All right. Okay, good. So I'd like to start with two patients that I saw at around the same time. It was back in 2013. This 23 years old lady just came back from Australia for her university studies. And upon landing, she noted that she developed a right face, arm, and leg weakness with a moderate physical disability. EDSS score is a measure of physical disability in multiple sclerosis. And for that, she was admitted to a private hospital, treated as a CNS demyelinating attack, and was given steroids. But shortly, she was able to be discharged. But shortly after her discharge, she developed new symptoms. This time is 2 months later. She developed vertigo, diplopia, dysarthria, and also ataxia. There was a very disabling attack. It was mainly on the brainstem and corticospinal tract, as you can imagine. So she was so disabled that she has to be quite bedridden for the period of time, needed care just to get out of the bed, and was very disabled. For that, we also give her another course of IV mifepristone. And also for this particular episode, we also give her IVIG as well. So she made some recovery in the subsequent weeks, but I think she was attempting to go home with home leave around May. But unfortunately, she developed another new attack during her home leave. I think she told me that she was unable to swallow properly, and she developed a new right arm weakness. So at that time, it was actually her third demyelinating attack. So as you can imagine, within 6 months or within the first few months of disease onset, she already have a few episodes of attacks, relapses, and also a period of improving or remitting stage. So at that time, we diagnosed her having CNS demyelinating disease, specifically relapsing multiple sclerosis. And given her very disabling and very frequent attack within a short period of time, we also diagnosed her condition as a highly active disease. So as I briefly mentioned, we'll come back to this again, that during the acute attacks, we gave her mifepristone. And in some of the attacks, we also supplemented with intravenous immunoglobulin IVIG. And of course, after each acute attacks, we actually gave her a short course of oral prednisolone as well. So this is like a standard treatment for acute attacks. But given her highly active condition, we also recommended, at that time, was first available in Hong Kong. In fact, she was the first lady to receive oral fingolimod at that time, which was one of the only oral medications that was indicated for the treatment of highly active multiple sclerosis. So with that treatment, she became very stable, no more attacks in the subsequent months. And but unfortunately, she cannot return to school immediately. So she was actually staying at home in Hong Kong. But in about 6 months' time, she made a full recovery and was able to fly back to Brisbane to complete her bachelor study. So in the subsequent few years, she was kept on fingolimod, and there was no evidence of disease activity, which was quite remarkable treatment response. I'd like to show you her MRI. Okay, so this is back in 2013, during her approximately second attack, because this is the scan from our hospital. As you can appreciate, this is the T2 sequence. You see the typical round or ovoid in shape periventricular lesions, okay, scattered around the periventricular region in this particular cut. And in this sagittal cut, this is the corpus callosum, the big white fiber tract connecting the left and the right cerebral hemisphere. You can also appreciate the ovoid lesions like perpendicular to the ventricular space. This is what we call the Dawson's fingers, all right? And of course, if you look down inferiorly, because of the brainstem symptoms and signs, we actually see many pons lesions and also the corticospinal tract lesions as well. As you can see, these are all the scattered lesions within the cortex or subcortical region, as well as the brainstem. The last panel, post-contrast, post-gadolinium contrast sequence. You can also appreciate that you can also appreciate that most, if not all, of the brainstem lesions were actually enhancing. Lesions that are contrast enhancing are actually recently active because we understand that if the lesion is being the most active one within the past 4 to 8 weeks, the blood-brain barrier is usually being damaged because of the inflammation, and therefore, if you inject gadolinium contrast, it will seep through the blood-brain barrier and make the lesions more enhancing. So as you can appreciate, the subcortical periventricular lesions are also contrast enhancing. So this is one of the most active MS patients that we've encountered. And subsequently, we put her on treatment, and this is 1 year follow-up imaging. As you can appreciate, many of the lesions have luckily regressed or become not very visible, but some of them also were left as a persistent or permanent T2 hyperintense lesions. Okay, so these are the classical changes that you will see in patients with confirmed or with a clinical diagnosis of multiple sclerosis. All right, so at that time, there were no contrast enhancing lesions, so it was quite stable condition. So this is the patient was at that time was in the remitting state. Of course, we follow her up again with a yearly scan, and as you can appreciate, in the 2015 scan, some of the lesions, because of the chronic inflammation, have progressed to become like a black holes, and this is the T1 sequence. As you can appreciate, they are also like a punch out holes here. So it's a T1 hypo-intense black holes, some of the lesions in the brainstem as well. So these are also some of the chronic changes that you would anticipate, that you would see in the patients with some duration of the disease state, all right? So contrast that to another patient presented around the same time, like I said, also the same age, 23 years old, also a university student at that time, but she was studying in Hong Kong, a local university. So in March 2013, she presented with bilateral optic neuritis. I said synchronous because the left eye and the right eye were affected within a very short period of time, actually within the same week. So symptom onset in one eye and then shortly followed by the other eye, synchronous bilateral optic neuritis. It was very severe because the visual acuity was affected only down to waving hands. Okay, so as you can imagine, this is a very poor vision. She was again presented to the private hospital first, given steroids, and then it was a partial response. Because of the poor vision, she again was on leave, sick leave at that time. And then we saw her at around here, a few months after the initial attacks. First assessment shows that, well, after 3 months treatment, in fact, her vision already improved to quite good condition. She was able to read and write and was contemplating to go back to school, well, after the summer break. At that time, the blood result came back, and it was the serum neuromyelitis optica IgG or NMO IgG, or specifically, it's actually the aquaporin 4 antibody. It was positive. So at that time, the follow-up imaging shows a normal MRI brain, no lesions in the MRI brain to suggest a multiple sclerosis. So at that time, we diagnosed her having NMO spectrum disorder. We strongly advised her to continue the immunosuppressants. So she was actually on steroids at that time. But as you can imagine, a young lady taking 3 months of oral steroids already have some side effects and she wasn't very happy to consider, although at that time we did not have a lot of clinical experience. I think retrospectively, now we would not give her time to think. We would just strongly encourage her to continue on immunosuppressants because she was weaning off the steroids, and then just a few weeks later, she developed another attacks. This time is more brainstem, hiccups, nausea, and vomiting. This is another classical attacks of NMO SD, not just optic neuritis, myelitis, but also the brainstem attacks, and that causes a lot of symptoms, more GI symptoms, as you can imagine. If she presented to one of our emergency departments, she was sent away because it's just like a gastroenteritis. And so being frustrated, she went to a private hospital. Every GI workup was arranged, including OGD and a CT abdomen. It was unremarkable. But eventually, a few days later, she developed some electrolyte disturbance, hyponatremia with SIADH picture, and then developed swinging fever, but without positive cultures. So her clinical course become deteriorated quite rapidly in the subsequent few days, and she developed dysphagia, blurred vision, and confusion. So she was sent to our hospital, and quickly she was also sent to the intensive care because of this reduced consciousness. In the ICU, unfortunately, she continued to deteriorate. Well, we treated her as a severe NMO attack with steroids, IVIG, but unfortunately, she developed other devastating complications, including autonomic dysfunction, hypothalamic dysfunction, brainstem dysfunction. So for a few days, her heart ran so quickly, stayed at persistent tachyarrhythmia with a heart rate of 160 to 180 persistently. So she ran into cardiac failure and developed cardiac arrest, and she succumbed to this severe attack. So she died in the ICU. So this was her clinical MRIs. During her initial few days, we were able to do the MRI scan. As you can appreciate, this is the optic nerve on the right side and the left side. Both optic nerve shows T2 hyperintense lesions, and this is the whole length of the optic nerve. This T2 hyperintense lesions extend at least half of the length of the optic nerve on the right side, also being scattered, but then also quite diffuse optic nerve and T2 hyperintense lesions on the left side as well. The hypothalamus is also being affected. Okay. The lower brainstem is also being affected. Okay, so this is the dorsal medulla region, the lower brainstem. This is quite classical of the brainstem attacks here. So this is not the best scan, but best cut or best image to show you the area postrema lesion. This is, if you read the more NMO scans, sometimes you could see the more prominent area postremia lesions that are typical of the NMO SD attacks. So just to highlight two distinct disease entity, one is a more relapse remitting cause, multiple sclerosis. The other is more devastating demyelinating attacks, NMO spectrum disorder. So what is MS? Well, we still believe that MS is the best understanding is that this is an autoimmune condition with a demyelinating attack of the central nervous system characterized by demyelination and axonal loss. Demyelinating attacks of the central nervous system should demonstrate the multiple aspect, which is dissemination in time and space, meaning that the CNS is being affected at different parts of the CNS at a different time point. So there must be a duration of the illness. Typical attacks would be typical lesion site of the central nervous system, including the brain, brainstem, cerebellum, spinal cord, and optic nerves. MS patients, well, unlike our first patient, the majority of them have more mild attacks in the initial stage, and 80% of them runs a relapse-remitting course after the disease onset. The problem is the initial stage, there might be some more full recovery or a full remitting condition, but with recurrent attacks, there will be accumulation of physical disability. So the clinical course, majority of them is relapse remitting, and after 10, 15 years, if there is no efficient or effective or efficacious treatment, then they might run into the secondary progressive phase. A few, or 5 to 10% of patients actually run a primary progressive forms, whereby they continue to slowly deteriorate since disease onset, and there's no clear remitting state in these patients. Well, in fact, MS is the most common autoimmune central nervous system disease worldwide, actually the most common neurological disease of young adults. I think up till 2020, I think we have more than 2.5 million young adults being affected by this condition. Quite interestingly, because we do not do brain biopsy in all of our patients, so the diagnostic criteria is mainly clinical, like many of the neurological diseases. So the key cornerstone to establish MS is to establish CNS demyelinating attacks that is disseminated in space, disseminated in time, and more importantly, exclusion of alternate diagnoses. So this has been the guiding principle since the first diagnostic criteria back in 1965, Shoemaker. This is actually the criteria set up for the clinical trial at that time to test ACTH or give corticosteroids as a part of a standard treatment to see if they respond. So, and then 1983, there was a time with the interferon clinical trial, so they actually updated the clinical diagnostic criteria, and followed by more evidence-based clinical criteria in the McDonald criteria era. So from 1965 to revisions of the diagnostic criteria to the latest one, 2017, I think we're incorporating a lot of the updated clinical evidence in terms of the sensitivity and specificity of the diagnostic tools, including the MRIs that we are using most often nowadays. Just a little bit on the pathophysiology. Now we understand that MS is both a T cell and B cell mediated disease. This is actually the classical description now is a chronic inflammatory, demyelinating, and neurodegenerative disease of young adults. We now know that neurodegeneration is actually part and parcel of the disease because of the chronic inflammation, not just affecting the white matter, but also affecting the gray matter as well. So that is actually the important cause of the neurodegeneration aspect. We don't know what exactly causes MS. It has to be multifactorial, immune-mediated, triggered by environmental and genetic factors. But the pathophysiology is a breakdown of the blood-brain barriers, whereby the immune cells that are usually activated in the peripheral circulations would passes through the blood-brain barriers and then causes inflammation and damage in the central nervous system. These sort of autoreactive T cells and B cells, after infiltration of the blood-brain barriers, actually lead into a secondary activation of the immune system within the CNS, the innate immune system, and in particular, microglial activation and astrocyte activation causes a chronic inflammation within the central nervous system. So there is both inflammation and inevitable neurodegeneration. So you can imagine that this is like a small fire or big fire in your backyard, whereby many, if not all of the current medications cannot get into the central nervous system to exert its effects. So the existing, most of the more established medications actually works best in the peripheral circulation. So the newer generation medications are trying to tackle this problem, whereby they could get into the central nervous system through the blood-brain barriers to also modulate the inflammation that is going on within the central nervous system. So to establish the diagnosis of MS, we rely on the McDonald criteria. So the 2017 criteria is a revision to the 2010 criteria. So we start here first. At that time, we have this term, so-called the clinical definite MS, whereby the three principles has to be satisfied: dissemination in space, in time, and exclude alternate diagnosis. So at that 2010 criteria, we were able to start diagnosing patients very early on in the disease state, specifically in the first attack. If during the first attack, we were able to demonstrate dissemination in space, such as lesions in different parts of the central nervous system, we always look at these four classical regions: periventricular region, just the cortical region, infratentorial region, and the spinal cord. We'll come back with some clinical pictures on these four important areas to look at. But once we have one attack, dissemination in space criteria, meaning that we see lesions in more than one of these four classical regions, and then we look for evidence of dissemination in time. And this is the time when we either have multiple scans, say you scan the patients today and then scan the patients again in a later time. If you see new lesions in the second scan, then this is an evidence of dissemination in time. At that time, we also look at presence of contrast enhancing lesions and non-enhancing lesions. So if you're on the same scan, you see both enhancing and non-enhancing lesions on the same scan, then you can infer that the disease has been going on for a period of time, more than a few months specifically. So you could infer that the disease has been there for a long time, fulfilling the criteria of dissemination in time. Well, because it was an early stage of use of MRI criteria to establish dissemination in time, so the panel at that time was a bit more conservative. So there's this rule that you cannot count the active lesion. If a spinal cord lesion and there was the spinal cord attack, you cannot count that contrast enhancing spinal cord lesion as one of the dissemination in time criteria lesion. So it was quite confusing because sometimes it is very difficult to delineate which lesion is exactly causing the symptoms. So it was a bit difficult to fulfill the dissemination in time criteria using the McDonald criteria 2010. So before we go on to see what we did with the 2017 revision criteria, let's focus more on the T2 or the MRI usefulness as a biomarker to detect disease activity. MRI has become a very friendly tool to neurologists, and much so for MS as well, because in MS, we can use MRI to look for both inflammation demyelination, both in the acute and chronic stage, as well as the neurodegeneration lesions. In the acute stage, we look for new lesions, new T2 or flare hyperintense lesions, either a new site with the new lesions, or sometimes we also count an enlarging lesion of pre-existing lesions. So say if you have one lesion that was there in the old scan, and then in this new scan, you see a much bigger lesion, this is also counted as new activity. Of course, if we inject contrast, we can also identify new lesions as active lesions, as contrast enhancing lesions, more acute lesions. In the chronic state, we look for the persistent T2 or flare hyperintense lesions. Many times you also see T1 hypointense or the T1 black hole appearance. All right. What about neurodegeneration? This is a little bit tricky to assess because we have to look for atrophy of the brain. So because the lesions, as we mentioned, the disease affect both the gray matter and the white matter. Patients with multiple sclerosis actually have brain atrophy rate faster than the normal aging population rate. And that rate is approximately 0.4% per year. So my brain is smaller than yours already because of aging. But patients with MS could lose their brain up to 1% or 2% per year without treatment. So this was actually a new marker of a neurodegeneration. So many drugs are actually able to bring down the brain atrophy rate to close to the normal aging rate as well. So where do we look for lesions? Well, this is the first site, periventricular lesions. Again, look for around the ventricles, subcortical regions, ovoid roundish lesions. In the temporal lobe, this is actually quite specific. We always look for lesions around the temporal lobe as well. All right. What about just the cortical? Well, just the cortical meaning just next to the cortex and also next to the white matter. So as you see, the U fibers are being affected here. All right, just next to the, this is the hypointense lesion and the corresponding just a cortical lesion as well. So if you are not in the periventricular region, but more close to the cortical ribbon or the cortex, then you can also appreciate the just the cortical lesions here as well. Brainstem and cerebellum refers to the inferotentorial region. So as you can appreciate here, the left side of the pons is being affected, right side up here. Some of the cerebellum lesions is also being affected here as well. Spinal cord. This is the sagittal cut. As you can appreciate, a small 1 vertebral column height in size. Lesions here, if you look at the axial scan, it's a little bit more peripheral in most instances. Okay, and other lesions in the cervical spine and thoracic spine here. All right, so these are the quite typical MS plaques. In terms of dissemination in time, we look for new and enhancing lesions. So in this particular scan, this is the same patient. This is the T2 sequence. This is the post-gadolinium contrast scan. As you can appreciate, we see 2 examples of enhancing lesions. One of them is this one. This is like a ring enhancement, and the technical jargon is open ring enhancement because it's an incomplete ring enhancing lesions. This is quite commonly seen. Another lesion here, also contrast enhancing, the small one. This might be a little bit early acute, subacute phase because this is more homogeneously enhancing lesions. This is more open ring enhancement. The difference, well, if you want to know, we propose that this is like the core is having some remyelination again, and then the rim of the lesion is still actively having undergone the remyelination. So there is an area of demyelination and remyelination in the same lesions. And of course, nowadays we can do more fine cuts of MRI scan that resembles more 3D reconstructions. So this is the current protocol that we have been using for the last 10 years already, almost 10 years already. This is same scanner, but 3 Tesla MRI scans, and we just use fine cuts now. So it's 1 millimeter thick for each cut. So if you go through the whole set, like here, just playing you the video to impress you, just focus on the middle panel here. You can appreciate this particular patient has very extensive involvement, both in the corpus callosum, the temporal lobe, and also it's coming up. Yeah, as well as the brainstem as well. This particular patient, you would appreciate, hopefully they're coming up now. Yeah, you can appreciate some of the black holes that are scattered around the brain. Not very atrophic if you want to look at the whole brain in this particular scan. So this is just the contrast sequence. I don't think we have a lot of contrast enhancing lesions in this particular scan. I should replace it with a more dramatic contrast enhancing lesions. All right, so in 2017, there is a revision because now we know that we have more drugs, we have more treatments, and we need to consider earlier treatment, and of course to address the issues of how to counter lesions being symptomatic or asymptomatic when they are contrast enhancing. More importantly, there is also this understanding of the cortical involvement in multiple sclerosis. So there is also a need to address these cortical lesions that are sometimes picked up in the advanced MRI imaging now. And then there is this small points that I did not discuss back in 2010, because we heavily rely on MRI scanners. So there is a rapid reduction of patients who undergo oligoclonal band or CSF analyses. So in this 2017 criteria, there's like a little revival of the usefulness of oligoclonal band, and encourage patients to undergo more lumbar puncture to exclude alternate diagnoses, and make sure they also have the oligoclonal band. Because up to 90% of patients with confirmed MS actually have oligoclonal band. So it has a good prognostic marker implication. So again, in 2017 criteria, there is some revisions. Specifically, we can detect for the presence of oligoclonal band, and if it is present, then it already fulfills the criteria of dissemination in time, because it has a high predictive value of conversion to clinical definite multiple sclerosis. So if you have a patient first attack, multiple lesions on the MRI scan, but without much contrast enhancing lesions to fulfill the criteria of dissemination in time, then you check for oligoclonal band. If it is also present, then it is a patient with relapsing multiple sclerosis. They do away the classification of symptomatic and asymptomatic contrast enhancing lesion. So now, if you see on the same scan that there is already multiple lesions, dissemination in space, and multiple at the same scan, both enhancing and non-enhancing lesions on the same scan, then it is already a fulfillment of both dissemination in space and dissemination in time criteria. Also, the cortical lesions is considered part and parcel of MS now. So to fulfill the dissemination in space criteria, there's not much change, except that apart from just the cortical lesion is also counted as one classical region of dissemination in space, or MS lesions now. And then in dissemination in time, you just look at whether there is at the same scan presence of both enhancing and non-enhancing lesion, irrespective of the timing of the baseline MRI scan. So again, this is the paper panels similar to our conditions. This is the periventricular lesions. This is the cortical lesion, special sequence called double inversion sequence. And then this is just a cortical lesion, brainstem or infratemporal lesion, and the spinal cord lesion, very similar to the ones that I just showed you with our own patient scans. And just to impress you on the presence of gadolinium enhancing lesions here, and on the subsequent scans, you see new lesions, new enhancing lesion as well. So this is the dissemination in space and time criteria based on the 2017 McDonald criteria. Okay, we move on to treatment. Well, this is the common graph that we show our patients, whereby we usually tell them that during their first presentation of the clinical isolated syndrome, this is their first attack. But once we could establish that there is the lesions on the MRI scan, many of them are asymptomatic or pre-symptomatic, then this is the time when the patient has a diagnosis of a relapsing multiple sclerosis. So with time, there might be some new relapses, but in the early stage, there would be remission without much physical disability. But in the more advanced stage, then there will be some accumulation of physical disability. Then after 10, 15 years, they might lapse into this secondary progressive phase, whereby they continue to deteriorate without much clinical relapses anymore. So this is the usual natural history. It takes many years from CIS, first attack, to relapsing remitting stage, to later secondary progressive stage. This particular line just show you the rare form of PPMS, primary progressive MS, whereby they continue to slowly deteriorate throughout the years since the disease onset. On the right side is the new treatment goals. I think many of the drugs, about 30 to 40%, 30 to 50% of the patients who are on the current treatments could achieve these highest treatment goals, which is no evidence of disease activity. By that, we mean that there is no clinical relapses. And if we use MRI to monitor the patients, there should be no new lesions, no enhancing lesions. And if we also could able to do brain volumetrics, there is no significant brain volume loss. And of course, during the clinical follow-up, we should not be able to detect any clinical or subjective or objective disability progression, meaning a neurological exam should be stable. So if you could achieve all these four pillars of treatment goals, then you achieve no evidence of disease activity. But of course, in real life, you could imagine that some of the patients might still have a few new lesions on the MRI scan. They might have very mild or trivial relapses. They may not be able to achieve a very dramatic reduction of the volume loss. So these type of patients, if they are doing very well throughout the years, we call them minimal evidence of disease activity, or MIDA. So to neurologists, it was very exciting 20 years of drug development, because many of the drugs that usually fail in other diseases, they become efficacious when the drug company invests in clinical trials of multiple sclerosis. So throughout the last 20 years, we have more than 18, or actually close to 20 drugs now that are proven to be effective and efficacious in randomized controlled trial. And most of them are published in New England. So we start with some interferon stage, but in the past 10 years or so, we start to have more oral drugs such as fingolimod, teriflunomide, B312 is Tecfidera or dimethyl fumarate. And then there is also this cladribine. On the right side, more injectable drugs, natalizumab, alemtuzumab, and also ocrelizumab. Rituximab has been used in older research clinical trials. This is 2008, but subsequently it was replaced by more humanized or newer generation of CD20 depleting monoclonal antibodies. The latest one is ofatumumab, and we should be able to get it in Hong Kong very soon as well. Lots of drugs. Do we have like a protocol or guideline in place to help us choose which drug? Unfortunately, not so, because MS is more complex disease. There is no unified consensus on when and how and which to use. Accordingly, the American and the European guidelines just publish a more general recommendation, whereby they give you some general recommendations on when to start drug, when to consider switching to another treatment, how to choose among the different disease-modifying drugs, the importance of having MRIs, and some general recommendation of stopping the treatments. It doesn't. This is not like many other diseases where I can show you a graph on the algorithm recommendation from, say, the European and the American Academy of Neurology. Having said that, there are some experts that write review articles on so-called evolving concepts in the treatment of relapsing multiple sclerosis. So there are two schools of thought you might hear. One is escalation, the other is induction, borrowing the idea of chemotherapy in oncology terms. So by escalation, we start with some more mild to moderate drugs, where you start the treatment first and then monitor the patient. If they do not do very well in terms of relapses or MRI activities, you consider to escalate to more efficacious drugs, so-called second line. And then the third line would be, say, research use only, or some of the clinical trial medications. So in these instances, interferons, dimethyl fumarate, teriflunomide are considered as first-line drugs. Second-line drugs would be natalizumab, fingolimod, and alemtuzumab. And the third-line drug would be more like rituximab or up-and-coming ofatumumab. But there is a group of patients, like the first patient that I described, where they start with a very aggressive disease or very active disease out front. So in these instances, many experts consider the use of induction approach, where we start with the more potent medications such as natalizumab, fingolimod, and alemtuzumab. The rationale behind is you want to bring down the inflammation as rapidly as possible to avoid long-term complications or long-term disability development. So there is this evolving concept of, or more like a debate on whether you would go more conservative or you go more aggressive, in depending on the patient's clinical profile. All right. So this debate is going on, but what is more agreed on is the acute management of MS relapse. So the treatment of choice is methylprednisolone intravenous. It promotes functional recovery, and the usual dosage that we give is 1,000 milligram or 1 gram per day for 3 to 5 days. So this is like our standard protocol. If a patient have relapses, we admit the patient for IV methylprednisolone for 3 days, and then after 3 days, we reevaluate the patients. If they show good recovery, and then we may not need the 4th and the 5th day methylprednisolone. If they just start to have some recovery, then we usually give them a full 5-day course of oral IV methylprednisolone. After that, we will switch them to oral prednisone for a short course, usually over 2 weeks. In patients who did not make a full or remarkable recovery after 5 days of steroids, intravenous steroids, we also offer IVIG as well. So what drugs do we have in Hong Kong? Well, under the hospital authority, we were able to introduce many of the existing drugs now. We are trying to fight for more resources, but I think it was already a dramatic improvement in the last decade already. Contrast that to 2 decades ago, when patients have to sell their houses, quit their job, and then borrow money from their family to buy the expensive medications. So first-line drugs, we now have interferon. There is 2 different formulations, interferon beta-1a and interferon beta-1b. They work as good as each other, just different preparations. Beta-interferon, as some of you imagine, it was used in part of the treatments for COVID. And the difference is this is like a alternate day injections. You have to inject every other day. Rebif is beta-1a, you inject 3 times per week. Ephonex is intramuscular injection, you inject once a week. And since 2017, we have 2 oral drugs, teriflunomide and dimethyl fumarate. And for patients who are more active, we could offer second-line fingolimod. Since 2013, it was under the safety net, whereby you still have to undergo a financial assessment before you could be eligible for some sort of subsidies, and then become a standard second-line drug since 2019. And now we also have alemtuzumab as alternate options for more aggressive diseases, and we also have natalizumab as well. So a brief summary, how we manage patients with MS. Well, we highly recommend to start treatment once you fulfill the McDonald criteria 2017. We recommend the check of CSF, lumbar puncture, to establish the oligoclonal band status and arrange an early MRI to establish dissemination in space and time criteria. But more importantly is to exclude alternate diagnosis that we are going to discuss on. First thing is NMO. The other is other up-and-coming autoimmune diseases of the central nervous system. As discussed, we have interferon, teriflunomide, and DMF as the first-line drugs, but there is always an option of fingolimod or other medications for highly active MS patients. We would then need to monitor the patients closely with MRI and follow-ups. MRI has to be done at least once a year. It's a standard recommendation. If resource allows, some of the patients, I have to ask them to do a private scan. Escalate to second-line treatments if there is any form of confirmed disease activity. And the options include fingolimod, alemtuzumab, and natalizumab. Patients who are still refractory to 2 or 3 drugs, or they could not afford the second-line drug if they fail the financial assessment, we sometimes offer them rituximab. Rituximab, now we have biosimilar with a dramatic reduction in cost to the patient, so this is an option. I do not have time to touch on natalizumab because there is a risk of PML in long-term use, and especially when they have a high index of JCV antibody levels. But unfortunately, in Chinese patients, we have a higher prevalence of JCV seropositivities and indexes. So very few patients are eligible to consider for natalizumab. And of course, we have newer drugs coming in as well. So in the next 15 minutes or so, I'm going to talk about NMO and other new diseases. Switch gear to NMO now. Well, NMO is called neuromyelitis optica, and And it is the classical description is actually by Professor Divik back in early 1990s and 1910s. So it was a rare autoimmune inflammatory diseases of the central nervous system. By name, it is affecting the optic nerve and the spinal cord, myelitis. But we also know that it affects the brainstem as well. This is related to the aquaporin in the astrocytes. Again, we went through a very confusing time of establishing a diagnostic criteria, and then some difficulties and challenges in establishing the confirmed diagnosis. So back in 2006, a few years after the identified the results of publishing of NMO antibody, specific antibody, the aquaporin 4 antibody, the NMO IgG, there is a diagnostic criteria. So if a patient have classical optic neuritis, myelitis, a normal MRI brain, and a very extensive myelitis on the spinal cord, and also, of course, a positive NMO IgG test, then there is this classical NMO diagnosis. But patients might present differently. They could have extensive myelitis, recurrent optic neuritis, but without occurring in the same patient. So there was this 2007 revision diagnosis on the term so-called spectrum disorder. So once we call a disease spectrum disorder, it becomes more problematic because we are sort of grouping a few similar phenotypic conditions into the same umbrella of diagnosis. So there were some variations at that time, but we now know that the aquaporin 4 antibody is a specific marker of disease. So in 2015, there is this revision of the diagnostic criteria. So I think I should discuss a little bit more on the 2015 criteria. Well, now we have this unified term, so-called NMO spectrum disorder, NMOSD. So the idea is we now always test for patients for the presence of aquaporin 4 antibody. And if it is present, we call this aquaporin 4 positive NMOSD. If it is negative, then we call this aquaporin 4 negative NMOSD. Aquaporin 4 positive NMOSD, like our second patient, is present. We can make this diagnosis if we have optic neuritis, myelitis, or area postrema syndrome plus the antibody. So you need no better explanation borrowing the idea of MS diagnosis, but you can allow some sort of MRI lesions, the classical NMOSD MRI lesions now, meaning the brainstem, sometimes in the cerebral syndrome as well. I'm going to show you some of the images. But if you do not have the aquaporin 4 antibody, then you need multiple presentations. Classical one would be optic neuritis, myelitis, and area postrema syndrome, but you need some other classical symptoms, meaning that you need actually 2 attacks in different NMO specific regions. So this, with this new criteria, patients should only present with recurrent neuritis, optic neuritis, recurrent myelitis alone, do not fulfill the criteria of NMOSD. All right, so you might look for additional MRI features and exclude alternate diagnoses. So I'm quickly going through this panel of NMOSD lesions. The spinal cord lesion is more central, as you can appreciate. The myelitis lesion is more extensive, usually extending up to 3 or more vertebral column in length. Optic nerve is affected, but very extensive, like our second patient. The optic chiasma could also often be affected as well. This is a better picture of the area postrema lesions that I want to show you. Dorsal medulla, very aqueductal region here. In the last panel, you see some classical changes in patients with NMOSD. Sometimes they have a more diffuse lesion in the brain. Contrast that to the MS plaques that are round and ovoid. All right. In terms of treatment, the acute treatment is quite similar to MS because like any CNS demyelinating attack, we offer intravenous methylprednisolone as the first-line treatment. But because of the severity of the attack, most if not all of the instances for NMOSD attacks, we give a full 5-day course of methylprednisolone followed by IVIG, and sometimes in refractory patients, we have to consider plasma exchange as well. There is a debate whether we can offer early rituximab in these patients, which actually have some good data showing. and whether there is a need of to combine IVIG and mifepristone in a patient who present with a very severe relapse. But in terms of preventive medications, we do not offer the MS medications, but instead we give them traditional immunosuppressants. Standard one would be oral prednisolone, followed by steroid-sparing agents such as azathioprine or mycophenolate. Rituximab, we always offer it, again, because of the availability of biosimilar formula. We could discuss this a little bit easier because the cost is much less now. So the idea is we borrow the rheumatology protocol. So we give an induction of 1 gram and 1 gram separated by 2 weeks. So it's a 2 gram induction course followed by a maintenance course every 6 months. Again, we advocate long-term maintenance treatment for NMOSD because although there is no secondary progression in NMOSD, but each attack leave a permanent damage to the central nervous system. So we need to keep the patients on maintenance therapy if they are diagnosed to have NMOSD. There are new drugs. Again, they are all positive clinical trials. They are all monoclonal antibodies. Eculizumab, complement 5 inhibitors. Satralizumab, IL-6 monoclonal antibody. And lastly, inebilizumab, a CD19, very close relative of a CD20, rituximab monoclonal antibody. So these 3 monoclonal antibody have shown to be efficacious in the reduction of relapses in NMOSD. We still haven't got the drug yet because they are extremely expensive, 1 million per year, Hong Kong dollars, $500,000, actually more for this one. And I still don't have a price tag for this one as well. So it has been a burden. We have the new drugs, but because of the expensive high cost, unable to introduce yet to our patients. Finally, patients with bilateral optic neuritis. Is it NMOSD? Well, she's a 57-year-old lady, accountant, with some cardiovascular risk factors. Again, she presented with bilateral blurred vision or synchronous optic neuritis. All right, right eye pain, visual loss, and then left eye pain, visual loss. Very bad visual acuity on presentation. MRI shows very extensive optic neuritis as well. At that time, we worried about NMOSD, obviously, because of the synchronous bilateral optic neuritis and intense involvement on the optic nerve as well. The LEON refers to long and extensive optic neuritis. Normal lumbar puncture findings. Well, interestingly, this lady has a rapid recovery when we were offering the intravenous IVMP mifepristone treatment. So, so much so that within 2 months, she made a full recovery. Nothing residual, not even color vision is being affected. And there is a resolution of the optic nerve. So, well, we don't know what we could test, so we repeated the NMO IgG. It was negative 2 times. So we thought that, well, it might be something else, but to be safe, prevent another relapse that could cause blindness or permanent damage, we offer her a course of immunosuppressant up to 1 year. And she has no relapse. So it was actually more like a monophasic disease. So with that, we were working with the immunology lab. And at that time, there is this MOG antibody that is becoming available to test. So we retest some of his old samples and turns out that she has a presence or positive MOG antibody. So in fact, she has this condition, so-called myelin oligodendrocyte glycoprotein, MOG antibody associated disease or related disease, or this is the MOGAD that we are talking about. So it's a distinct disease activity, seems to be overlapping with a little bit of MS and a little bit of NMOSD. So this becomes our challenge, our current challenge, today's challenge, meaning that patients could present with optic neuritis, myelitis, or even encephalitis that we did not have time, autoimmune encephalitis, or more ADEM-like conditions. So in this particular new presentations, we need the tests, MRI, antibodies, CSF oligoclonal band. So you might be able to see a more classical MS patients or more classical alpha-4 positive NMOSD patients. But then there is this great overlap of, say, MOGAD patients, that some overlapping features with MS, some overlapping features with NMO SD, but they might have carry the MOG antibody as well. So there is this overlap of 3 diseases. So how do we manage patients as a summary approach? So these patients always present with some sort of CNS demyelinating condition, optic neuritis, myelitis, brainstem lesions, encephalomyelitis, okay, more brain involvement in these instances. So luckily we could offer MRI, arrange MRI as soon as possible to delineate the extent of the lesions. And of course, at the same time, we do tests and treatment, okay? So treatment, first-line treatment, luckily, most of them it's the same approach, which is to offer them high-dose intravenous mifepristone. If they do not respond well, we have the option of offering IVIG or more aggressively plasma exchange. At the same time, we test for the patient, say, aquaporin-4 antibody, MOG antibody, and repeat analysis. Okay, if you suspect another condition, autoimmune encephalitis, we might need to check for NMDA or other autoimmune encephalitis panel, such as GFAP or NMDA receptor antibody. And we make a diagnosis of central nervous system demyelinating disease, okay? Inflammatory demyelinating disease, IDD. So if we could establish a diagnosis of relapsing MS, we could start the MS-specific drugs. But for other conditions, such as NMO spectrum disorders or MOG, EM or MOGAD, we have to consider for immunosuppressive. So I'm trying to make a very complex clinical scenario into a very simple clinical approach as a summary slide for this particular lecture. There is very variable presentations and a lot of clinical thinking and decision has to be made during this diagnosis and management processes, but this is the challenging and actually the fun part of working in neurology. So I hope this is a good summary slide for you, and I would end the lecture here and see if you have any questions.